Good morning. I'm Dr. Jonathan Kahn here in Chicago with Dr. Peter Hersh. Good morning and welcome to the program.
Jonathan, thank you very much.
It's so great to have you here, Peter. I know that you've done a lot of work with corneal crosslinking. Can you tell us a little bit about your work and the specific topic that you're presenting on here at the conference?
Sure. We've been working with crosslinking now for almost 8 years in clinical trials of various sorts. And today we're talking about, how is cross-linking being adopted in the U.S.? We don't have FDA approval as yet, but even still, there is a lot of R&D that's going on in the U.S. And indeed, over 100 sites are doing cross-linking on a number of clinical trial protocols.
Great. Where do we stand in terms of FDA approval with this technology? I know that there are several phase 3 trials still ongoing. Do you think that there may be an approval coming up soon?
Well, the original trial, which began some 6 years ago now, was a multi-center trial of the standard cross-linking technique for keratoconus and corneal ectasia. That trial has been completed, and an NDA resubmission to the FDA was just sent in September of this year. So the 6-month date at which we may hear something from FDA is next March of 2015.
Well, we eagerly hope to hear a decision in the right direction. As you and I both know, there are plenty of patients here in the U.S. who really require cross-linking for their ectasia, and it would be great to be able to offer them that technology on an FDA-approved basis.
Yes, I think the clinical trials show that it really is an effective technology for decreasing the progression of keratoconus and corneal ectasia. And it's a field that's been great interest worldwide over the past several years, so it's rapidly developing both in its technique and the types of equipment that we're using.
Peter, do you think that the technique will continue to evolve? I know that, for example, some of our colleagues in Europe have been showing good data regarding epi-on cross-linking. Do you think that that's a procedure that we can adopt here in the U.S. as well?
Well, people have been very interested in epi-on cross-linking. It has the obvious advantages that there's no epithelial defect, so healing time's faster, comfort's faster, and risk of infection is less. The concern that we have thus far is the efficacy, especially the long-term efficacy, as good. There are a number of factors that might mitigate against a complete cross-linking response: absorption of the incoming ultraviolet by the epithelium, no oxygen, which can diminish the oxygen-dependent pathways of cross-linking, and different wound healing effects. So we have a lot to learn, but there have been a lot of inroads, new riboflavin formulations, new techniques that might make the epi-on technique, we hope, as valuable as the traditional technique.
One more quick question, Peter, is that there's been some discussion now about age stratification in collagen cross-linking. For example, some physicians advocate for cross-linking at younger ages, but that it may not have benefit after age 40, for example. Do you have an opinion on this age stratification, and how do you apply that to your patients?
Well, we actually did some work on this. We did a multifactorial analysis to look at what particular individual characteristics might affect the outcome for good or for bad. We look at best corrected vision, gain in best corrected vision, loss in best corrected vision, as well as change in the maximum keratometry on corneal topography. All we found actually was that there was no age effect per se. Those patients who had worse cones tended to improve the cone more, and those patients who had worse vision had a greater tendency to improve their vision. All patients were equally likely to be stabilized afterwards. Now, clearly, the main purpose of cross-linking today is to stabilize the progression of keratoconus and ectasia, and those patients who are detected at an earlier age are in an age range where the progression is likely to be more. So clearly, I think those are patients we're going to want to look at very carefully and perhaps treat as early on as we can, but certainly there can be some advantages for older patients as well.
Well, that's terrific, Peter, and I really appreciate your coming to speak with us about this today. It's a very exciting topic and technology that we hope to see soon in the U.S. under FDA approval.
Very well, thanks very much for having me.
Thanks, Peter.